This is J. Randall Wilkerson, author of the Heart Failure Recovery Plan, Successful Heart Regeneration Using Metabolic Enzymes. This is part 11 in a 58-part video series of every chapter and subchapter in this book. If you haven't already, please review the introduction video from our channel on YouTube. Part 11 covers the amino acid L-carnitine. This follows our CoQ10 discussion. L-carnitine is classified as a conditional amino acid. It can be manufactured from lysine and methionine. Persons with heart failure are typically suffering a serious deficiency of L-carnitine. Carnitine is a compound found abundantly in healthy heart tissue because it transfers ATP energy production through fatty acids, which is crucial for heart energy source and recovery from heart failure. It works differently than CoQ10 to create greater heart muscle energy and therefore more blood flow to enable the heart to heal and the body to maintain production. In many clinical studies, mortality rates for test subjects taking carnitine are dramatically lower even among patients who have already suffered major heart attacks. It was not until 1973 that disease conditions were discovered in humans because of carnitine deficiency. There are three main types of carnitine on the market. The most cost-effective method for restoring damaged heart muscle output is carnitine fumarate. It's a reasonable cost item. Acetylcarnitine is another version that primarily works to improve acetylcholine in the brain because it crosses the blood-brain barrier. Many clinical trials actually review a third type called glycine propionyl L-carnitine, or GPLC. It performs very well in establishing blood serum levels of carnitine, yet it costs 400% more than carnitine fumarate from the same brand. You can boost absorption 200% by taking carnitine fumarate with at least 500 milligrams of lysine. An early clinical study in 1992 discovered that carnitine had deficiencies among persons with heart failure, and when they added it to the diet, 55% of the test subjects improved so much that they were moved to a lower heart failure class. A lower heart failure class generally means that you can improve to full recovery, and that is to the point that you are not terminal, you're not dying. 66% of those test subjects have been listed as improved. There are many more clinical studies listed in the book. One listed in Cardiology magazine in 2010 showed improvement in test subjects even with mild heart failure. Now, there is one false alarm study, and these studies, I call them false alarm studies because they're created strictly to cause persons to avoid using the supplement. Who funds the study? We don't know exactly in every case, but what happened is there was an article that appeared in Nature magazine saying that carnitine causes heart disease. Very few people actually read the report. What it involved was a sensational fraud study in which they took mice, not humans, that were genetically engineered to be vulnerable to heart disease. Then they checked the intestinal bacteria of the mice for TMAO because it has been known in mice to cause or accelerate the development of heart disease, especially in the presence of carnitine from meat. Now, no evidence in humans exists to support this study. It was totally a groundless theory based on no real evidence. A urinary excretion of TMAO is higher with tomatoes, soybeans, peas, cauliflower, carrots than with beef, yet those foods do not trigger heart disease. Other test subjects were reviewed, mainly women who had the extremely low level of exercise and also were smokers. They assumed that those women who ate carnitine in red meat had increased heart disease because of the carnitine rather than the self-destructive lifestyle. So follow-up studies highlighted these anomalies and showed that humans need carnitine, this major amino acid, for heart failure recovery. A clinical test listed in this book often starts at 2 grams or 2,000 milligrams of carnitine per day. With all enzymes, it's best to take them with food spaced out over the whole day. So we recommend starting with 1,000 milligrams at breakfast, 500 milligrams for lunch and dinner. You could increase the quantity and still be fine, but start off with lower dosages and see how they work. Some medicines can cause carnitine deficiency. For example, valproic acid, which is an antiepileptic agent, can exhaust your carnitine levels. Some chemotherapy drugs will eliminate it. And as we grow older, we absorb much less from our diet. Insufficient carnitine can lead to many other different diseases, and it also is useful for removing lactic acid from heart muscle tissues. So when you're engaged in exercise, you may feel weaker if that lactic acid is not removed. In summary, the kidneys remove excess carnitine from the body through the urine. So therefore, side effects are very rare and minor. For some people who are susceptible, it can include diarrhea, insomnia, or the formation of trimethylamine, which is a gas that smells like rotten fish. But in general, clinical trials have gone as high as 9,000 milligrams per day. Take what you need to restore your energy level. Don't take any extra. That concludes this part. My name is J. Randall Wilkerson. I'm the author of the Heart Failure Recovery Plan, Successful Heart Regeneration Using Metabolic Enzymes. This book is available at Amazon in print and Kindle edition, at Apple iTunes in the iBooks version, on eBay in the print edition, and from the publisher Wilkerson and Hughes, P.O. Box 777, Altoona, Florida 32702. Just include a check for $24 and we'll send a copy right out. Thanks for listening.